Welcome back to yet another sketch in our hematology and oncology series. We've covered the malignancies of premature and mature B cells and T cells, and now it's time to focus on a special type of B cell, the plasma cell. This sketch is dedicated to the plasma cell dyscrasias, specifically multiple myeloma, monoclonal gammopathy of uncertain significance, and Waldenstrom's macroglobulinemia. Huzzah! Plasma cells, remember, are mature B cells that head back to the bone marrow where they secrete antibodies. Plasma cell dyscrasias are characterized by malignant proliferation of plasma cell clones in the bone marrow, at which point they get all crazy and start pumping out monoclonal immunoglobulins called M proteins. This is highlighted above the archery targets by that bone sign. Inside the marrow, we've drawn some antibody archers, a recurring symbol for antibody secreting B cells. Notice, too, that the archers are alike, meant to represent monoclonal plasma cells secreting monoclonal antibodies. Though, in reality, there is some clonal heterogeneity which contributes to relapse and drug resistance. The most prevalent of these plasma cell disorders is multiple myeloma, embodied by our first archer of the tournament, Sir Milo. In multiple myeloma, neoplastic plasma cells produce tons of copies of IgG or IgA immunoglobulin, represented here by the single and double-ended IgG and IgA arrows. Less commonly, IgM, IgD, or IgE are produced. In many cases, these neoplastic plasma cells are also pumping out free light chains. In fact, in up to 20% of myeloma cases, neoplastic plasma cells secrete light chains only. These light chains are dubbed Bence-Jones proteins and are embodied by Sir Jones over here, sporting a light chainmail. Increased age is a risk factor for all plasma cell dyscrasias. The average age of diagnosis for multiple myeloma is between 65 and 70 years old. Younger patients typically have a better prognosis. Multiple myeloma is 2 to 3 times more common in African Americans versus Caucasians. Many patients will present with constitutional symptoms, such as fatigue and weakness. About 75% of patients have anemia at presentation, which contributes to fatigue. Hypercalcemia is another common complication of multiple myeloma, also associated with fatigue and weakness. About 25% of patients will present with weight loss, which is why Sir Milo's caddy back there is looking a little thin, to say the least. In areas of bony involvement, increased osteoclast activity promotes the development of osteolytic lesions. This leads to bone pain, a common presenting feature. Pain is often in the back or chest and induced by movement or change in position. Pathologic fractures can occur as well, especially of weight-bearing bones and vertebrae, and patients may even be noticeably shorter because of vertebral fracture and collapse. Over in the practice area, I want to briefly cover hypercalcemia, represented by that stack of milk bottles. 25% of patients are likely to present with hypercalcemia on labs, though it can be asymptomatic, especially if it develops chronically. Serum calcium increases because of increased osteoclast activity, leading to increased bone resorption. Mild hypercalcemia can cause symptoms of constipation, fatigue, and depression, as depicted by this fatigued, depressed guy shooting some plungers, a recurring symbol for constipation. More severe hypercalcemia may present with polyuria, polydipsia, dehydration, anorexia, nausea, muscle weakness, and mental status changes. Check out our hypercalcemia sketch for a more in-depth discussion. Multiple myeloma is also associated with immune dysfunction and, consequently, an increased frequency of bacterial infections such as pneumonia and UTI. So we've drawn in some recurring bacterial lanterns. Impaired immune function is a result of lymphocyte dysfunction, as well as impaired function of normal plasma cells, which leads to decreased levels of normal functional antibodies in the serum. A small minority of patients with multiple myeloma or Waldenstrom macroglobulinemia also develop AL amyloidosis. So we've brought in Joan of Arc, our amyloid armored lady. Amyloidosis is a systemic disease characterized by extracellular deposition of protein fibrils in organs and tissues throughout the body. AL-type amyloid, specifically, is composed of protein fragments derived from immunoglobulin light chains, as depicted by the light chainmail she's wearing. And because these light chains form insoluble fibrils in an anti-parallel beta-pleated sheet configuration, she's always wearing that beta-pleated skirt. One of the most common manifestations of AL amyloidosis is renal injury. usually presenting as an asymptomatic proteinuria or overt nephrotic syndrome. We'll get to that in a bit. That's not all, though. Fibrils deposit pretty much everywhere, causing restrictive cardiomyopathy, peripheral neuropathy, hepatomegaly, macroglossia, purpura, and bleeding diathesis. All right, physical exam time, specifically a neuro exam. The most common neurologic complication of multiple myeloma is radiculopathy, usually in the thoracic or lumbar region. On exam, it presents with unilateral weakness, pain, or sensation loss in a nerve root distribution. Just think of this pinched neuronal bowstring. Radiculopathy is caused by vertebral bone collapse, or more commonly, a paravertebral plasmacytoma that compresses a nerve as it exits the spinal column. What's a plasmacytoma, you ask? Plasmacytomas are plasma cell tumors that may occur in the bone or in soft tissues, dubbed medullary and extramedullary lesions, respectively. Plasmacytomas can even rarely be seen on physical exam as purplish subcutaneous masses. We've given this girl a little quiver of antibody arrows to evoke an image of a little mass of neoplastic plasma cells just forming a tumor and doing its own thing outside of the marrow. We even gave her a purple polka dot dress to remind you of those purplish tumors that can form under the skin. Plasmacytomas may be seen in patients with multiple myeloma, but can also occur in isolation, in which case it's called a solitary plasmacytoma. Before we move on from the physical exam, a word of warning. If your patient has severe back pain and or hyperreflexia, decreased strength of the lower extremities, ataxia, or new onset urinary retention, you should be thinking spinal cord compression. It may be caused by a plasmacytoma or a bone fragment from a vertebral fracture. This is a medical emergency that requires immediate imaging. MRI is the diagnostic test of choice, symbolized, as usual, by a magnet. Alright, let's get some labs. As we've already discussed, anemia is a common feature of multiple myeloma. In fact, a normochromic normocytic anemia is seen in over 70% of patients at diagnosis and will develop in over 90% of patients at some point in the course of disease. Anemia is symbolized by that falling H-shaped abacus with little RBC heads. Think of it as a falling H and H. What's happening here? Well, the bone marrow is getting replaced by tumor cells, leading to suppression of normal blood cell production. RBC production is affected first, but as the disease progresses, other cell lines may decline as well, leading to thrombocytopenia or leukopenia. In addition to a CBC with diff, examine the peripheral smear. You may see red blood cells sticking together, resembling a stack of coins. This is called rouleau formation, and it's a sign of increased serum protein levels. We also look for leukopenia or thrombocytopenia on the smear. Remember, there can be all kinds of penias with multiple myeloma. We already discussed hypercalcemia, but since we're talking about labs, just a little reminder that serum calcium will be elevated in over 25% of patients at presentation. It's caused by increased osteoclast activity and bone resorption. Multiple myeloma might also be suspected in a patient with an increased total serum protein concentration, which is measured on the comprehensive metabolic panel. You'll also find albumin on the CMP, and if you calculate the difference between the total serum protein and albumin, you've just measured the protein gap, my friend. Also called the globulin gap or gamma gap or paraprotein gap. The idea here is that albumin accounts for the majority of serum protein. But in the setting of viral infections or plasma cell malignancies or autoimmune conditions, there's an excess of immunoglobulins, raising the total amount of serum protein. That's the gap. In general, a difference between total protein and albumin above 4 grams per deciliter is considered to be elevated. So, make sure to mind the gap in front of the butcher stand. Notice that we've incorporated the 4 into the sign as well. We thought of everything. Now, this test is not too specific, obviously, but it should at least increase your suspicion of a paraproteinemia. You might also notice that the ESR is elevated. This is another little lab quirk caused by all those circulating monoclonal proteins, which can increase the serum viscosity and erythrocyte sedimentation rate. Since it's a result of increased viscosity and not necessarily inflammation, CRP levels may be normal if checked. Anyway, we've brought in our recurring symbol for ESR, a wind chime that resembles tubes of RBC sedimentation. And as the snack cart rolls in, remember to check the BUN and creatinine, represented by those bun burgers next to that creatinine credit card sign. Creatinine will be elevated in 20 to 50% of patients at diagnosis, a sign of renal insufficiency, which, in the setting of multiple myeloma, can be caused by all kinds of things. There are four etiologies we'll cover in this sketch: two common ones, hypercalcemia and light chain cast nephropathy, and two not so common ones, AL amyloidosis and light chain deposition disease. Let's start with the common ones. Light chain cast nephropathy is the most common cause of AKI in patients with multiple myeloma, which is why we've drawn in our recurring AKI symbol, an acutely cracked kidney. Though keep in mind that light chain cast nephropathy can also present chronically. It occurs in the setting of increased serum light chains. You know, those Benz-Jones proteins we talked about earlier. These little light chains are so small, in fact, that they're freely filtered across the glomerulus. That's when problems arise. As you can see, Sir Jones over here is an avid chainmail smith, and those light chain sleeves he's making are accumulating underneath him. Kinda like elongated tubular casts. Wouldn't you agree? This represents an overload of light chains getting stuck in the tubules, where they cause tubular damage and form obstructive intratubular casts. AKI, here we come. Another common cause of kidney impairment is that get dang hypercalcemia. Just ruining everything yet again. It turns out that calcium can injure the kidneys in more ways than one, actually. Hypercalcemia messes with the kidney's concentrating ability, which leads to polyuria, and if not replaced, depletion, renal vasoconstriction, and a pre renal AKI picture. Also, with long standing hypercalcemia, you can actually start calcifying and killing off those tubule cells, as well as precipitate some serious interstitial fibrosis. Alright, how about AL amyloidosis? Well, in this case, light chains form insoluble fibrils that deposit into kidneys. So we added some light chain mail to this amyloid armored lady's kidney shield. This causes asymptomatic proteinuria or even overt nephrotic syndrome, which is characterized by heavy proteinuria. So we've added some frothy, proteinaceous, and undeniably dark ages water underneath her. And finally, another less common cause of renal dysfunction in the setting of multiple myeloma is light chain deposition disease, the most common subtype of what are called the monoclonal immunoglobulin deposition diseases. Light chain deposition disease presents with renal disease similar to AL amyloidosis, except that the light chain fragments do not form fibrils. Instead, these fragments are deposited into tissues. Kinda like these light chainmail rings here, deposited into Sir Jones' kidney sac. Like AL amyloidosis, it presents with renal insufficiency and nephrotic syndrome, which is why the kidney is sitting in that frothy, fetal water. If there are signs of renal insufficiency on labs, perform a complete AKI workup to look for reversible etiologies you can treat right away. For that whole ball of waxy casts, head on over to our AKI sketch. With reversible causes ruled out, getting a more precise diagnosis of the cause of kidney disease is going to require a few extra tests, which we'll get to as we work up our patient for multiple myeloma. Let's take a look at the diagnostic tools we have at our disposal. In front of this protective screen, we're going to illustrate the two big tests we use for screening: a serum-free monoclonal light chain analysis, in addition to a serum protein electrophoresis, abbreviated SPEP, with immunofixation and quantitation of immunoglobulins. Let's start with that SPEP. Serum protein electrophoresis separates serum proteins by net charge and size. Immunofixation and quantification just means that we identify which specific antibodies or antibody fragments are present and how many. In the setting of multiple myeloma, the SPEP will almost always display an M spike, a single narrow peak in the gamma globulin region that represents the monoclonal protein, or M protein, secreted by the neoplastic plasma cells. The M spike in multiple myeloma is usually IgG or IgA. Rarely other immunoglobulins will be seen. Also remember that, in many cases of multiple myeloma, neoplastic plasma cells pump out lambda or kappa light chains. You'll be able to spot these as well. A serum-free light chain assay should also be ordered, increasing the sensitivity of the screening process to at least 97%. It's especially useful for identifying patients with AL amyloidosis or multiple myeloma with predominantly free light chains. That's why we've placed this bin of free light chainmail in the vicinity of Sir Bence Jones and our amyloid armored lady. Notice, too, that we've got some serious bloody leakage from the butcher stand over here, emphasizing that these two screening tests are serum tests. But it turns out that we can test the urine as well. The SPEP and serum free light chain assay are typically all we need for screening. However, all patients found to have a plasma cell dyscrasia will get a urine protein electrophoresis with immunofixation. The UPEP is just like SPEP, except this time we're detecting M proteins in the urine. And then we use immunofixation to identify which specific antibodies or antibody fragments are present. A 24-hour urine collection is performed, which helps us get a baseline value of the total amount of protein, and specifically M protein, excreted in the urine per day. This is useful later for determining the burden of disease and the response to therapy. But UPEP is also especially good at finding free light chains that have passed into the urine, those pesky Bence Jones proteins we discussed earlier. So we've made sure to add not just an M protein spike helmet to this bin sitting in the urine puddle, but also some free light chainmail. All patients should also get a routine urinalysis. Remember that multiple myeloma and amyloidosis can damage the kidneys in all kinds of ways. Check the urine sediment for anything funky. Also, keep in mind that the protein level measured on dipstick is really a measure of urine albumin. A dipstick won't detect light chains or immunoglobulins. Let's put this all together and diagnose a few of the renal syndromes we introduced earlier. First of all, rising creatinine should clue you into some kind of renal injury. On urinalysis, AL amyloidosis and light chain deposition disease typically present with a markedly positive dipstick for protein, which should be expected since both of these diseases cause proteinuria or even overt nephrotic syndrome. Most of this urinary protein is comprised of albumin. So, we've added our recurring albumin album symbol to that frothy puddle beneath them. And how about light chain cast nephropathy, the most common cause of AKI with multiple myeloma? Well, the urine dipstick is usually negative for protein because the proteins passing into the urine are those itty bitty Bence Jones proteins, and not albumin. A presumptive diagnosis of light chain cast nephropathy can be made instead with a serum free light chain concentration of greater than or equal to 1500 milligrams per liter, in addition to a predominance of monoclonal light chains on that UPEP. In other words, if there are lots of light chains in the serum and lots of light chains in the urine, you can be pretty confident that it's light chain cast nephropathy causing that rise in creatinine. Patients who do not fall into this light chain cast nephropathy category, including patients with the predominance of albumin in the urine or an abnormal urinary sediment, will likely receive a kidney biopsy. This will definitively diagnose the cause of kidney injury, such as amyloidosis, light chain deposition disease, or any of the various nephritic or nephrotic syndromes. Alright, let's wrap up our workup of suspected multiple myeloma with just a couple more labs. Beta 2 microglobulin and LDH are usually ordered as part of the initial screen for multiple myeloma and are symbolized here by the lactate dehydrated milk, along with this medieval baker's 2 beta hair buns. If a diagnosis is made, LDH and beta 2 microglobulin help determine prognosis and guide therapy. The higher the levels, the greater the disease burden. Patients with suspected multiple myeloma should receive cross-sectional imaging to look for lytic skeletal lesions with one of the following modalities: whole body low-dose CT without contrast, whole body combined PET CT, or whole body MRI, all of which are embodied by Sir Milo's trained arrow-retrieving cat. The black cat is our recurring symbol for CT, the magnet is our symbol for MRI, and that service PET vest symbolizes PET scan, of course. Until recently, a skeletal survey composed of plain radiographs was the standard test for detection of bone lesions in suspected multiple myeloma. However, cross-sectional imaging is more sensitive and is now preferred. Imaging may also reveal plasmacytomas, those medullary or extramedullary plasma cell tumors we talked about earlier. In fact, a small minority of patients will have a solitary plasmacytoma and no other findings, though a significant number of these patients will progress to full-on multiple myeloma within a few years. Bone marrow biopsy is essential for the diagnosis of plasma cell dyscrasias. Biopsy results for multiple myeloma will usually show at least 10% abnormal clonal plasma cells in the marrow. So, underneath that bone banner, we've turned the archery target into a plasma cell, with a flag next to it forming the number 10. As in, 10% of the marrow is composed of neoplastic plasma cells. The bone marrow samples should also be examined with immunophenotyping, cytogenics, to look for abnormal karyotypes, and FISH. The definitive diagnosis of multiple myeloma requires the following: bone marrow biopsy showing greater than or equal to 10% clonal bone marrow plasma cells, or a biopsy proven plasmacytoma. The target symbolizes the plasma cells, while the little antibody archer dude represents the presence of a plasmacytoma, which can be bony or extramedular. On top of this first requirement, you need evidence of end organ damage, specifically one or more of those classic crab features. That's increased plasma calcium level, renal insufficiency, anemia, or lytic bone lesions. Keep in mind that when I say crab symptoms, that requirement can also be fulfilled by certain biomarkers associated with eventual progression to end organ damage. The specifics are beyond the scope of this sketch, but just remember that diagnosis needs neoplastic plasma cells along with end organ damage or markers that indicate high risk of end organ damage. Let's summarize the clinical presentation of multiple myeloma in a sample assessment statement. Mr. Milo is a 70-year-old African American man presenting with new onset low back pain, fatigue, and constipation. He has no significant medical history. Physical exam is significant for pallor and spinal tenderness of the lumbar area with no sensory or motor loss. An X-ray of the lumbar spine reveals fractures involving the L1 to L2 vertebrae. His hemoglobin is 10.4 with an MCV of 92. Absolute neutrophil count is 1.4 times 10 to the third. He has a creatinine of 2.8 and a calcium of 12. SPEP demonstrates a monoclonal IgG protein of 1.8 grams per deciliter. Serum kappa free light chain is elevated. Given Mr. Milo's hypercalcemia, renal impairment, anemia and neutropenia, vertebral fracture, and SPEP results, the most likely diagnosis is multiple myeloma. After diagnosis and staging of multiple myeloma, optimal treatment consists of an autologous hematopoietic stem cell transplant. This is associated with better survival compared to chemotherapy. However, transplants are usually reserved for patients who are younger, with less serious comorbid disease and an early stage of myeloma. Transplant candidates usually receive 4 months of induction chemotherapy to reduce the number of tumor cells, followed by stem cell collection. If patients are not transplant candidates, chemotherapy is the preferred treatment. The regimen often includes bortezomib, a proteasome inhibitor. Since plasma cells are all about protein synthesis, it makes sense that they're particularly sensitive to proteasome inhibitors. Patients with unrelenting bone pain may choose to have palliative radiation therapy. If patients have symptoms of cord compression, start steroids immediately, usually dexamethasone, but patients may need a combination of surgery and radiation therapy for definitive treatment. At Sketchy, systemic glucocorticoids are symbolized by an eerie moon face, like this one, evoking an image of the moon phases that can occur with long-term steroid use. Patients with multiple myeloma and osteopenia, osteoporosis, or osteolytic lesions on imaging should be on a bisphosphonate such as pamidronate or zoledronic acid to decrease the risk of fracture and help reduce bone pain. Alright, before we wrap up the festivities, I just want to briefly highlight monoclonal gammopathy of uncertain significance, or MGUS. MGUS is an asymptomatic, pre-malignant clonal proliferation of plasma cells. MGUS is embodied by Sir Gus over here. I mean, just look at this guy. Yeah, I guess there's some plasma cell antibody secretion going on, or whatever. But this wacky old coot couldn't cause a lytic lesion even if he wanted to. I don't think he even knows where he is right now. So don't expect any symptoms or end organ damage. Instead, MGUS is typically discovered incidentally by lab results. Like multiple myeloma, MGUS is generally a disease of the elderly, with an average age of diagnosis around 75 years old. As you can tell by his spike helmet that resembles Sir Milo's, MGUS is associated with an M spike on SPEP. This monoclonal protein is usually IgG and less commonly IgM, IgA, or IgD. Hence the IgG-shaped arrow he's haphazardly loading onto his bow. Take a close look at that bow, as a matter of fact, and you'll notice that it forms a less than 3. To qualify as MGUS, the M spike must be less than 3 grams per deciliter. Not all patients with MGUS require a bone marrow biopsy, but if one is performed, expect less than 10% of neoplastic plasma cells. Patients with MGUS do not require any treatment. They are monitored, however, because of a small risk of progression to multiple myeloma or another malignant plasma cell dyscrasia. This is why he's dressed up as Sir Milo. He's like a multiple myeloma wannabe. Patients with MGUS have about a 1% chance per year of progressing to multiple myeloma, Waldenstrom's, amyloidosis, or another lymphoproliferative disorder. All right, time for our last competitor, Sir Waldenstrom. Waldenstrom's macroglobulinemia is a clinical syndrome caused by a lymphoplasmacytic lymphoma in the bone marrow. While hiding out in the marrow, it pumps monoclonal IgM immunoglobulins into circulation. Hence Sir Waldenstrom's projectiles of choice, IgM shurikens. Recall that IgM forms large pentamers. In Waldenstrom's macroglobulinemia, the massive volume of IgM pentamers is enough to significantly increase serum viscosity, leading to a hyperviscosity syndrome, represented here by this viscous mud gunking up the archery range. Sluggish blood flow in the central nervous system can cause headaches, tinnitus, and vision changes. If severe, it can lead to confusion or even coma. In the peripheral nervous system, sluggish blood flow can lead to a distal symmetric sensoromotor peripheral neuropathy, which presents with paresthesias and weakness, particularly in the lower extremities. Notice that we've given Sir Waldenstrom Squire over here some stockings and gloves, representing the typical stocking glove distribution of peripheral polyneuropathies. There's also a tendency for bleeding because the excessive amount of IgM interferes with clotting factors and platelet function. Patients may report frequent bleeding from the nose or gums. Don't mean to sound mean or whatever, but it really is his fault for standing there. Waldenstrom's macroglobulinemia is also associated with cryoglobulinemia, in which the IgM pentamers precipitate and deposit at low temperatures. This can manifest as Raynaud phenomenon, as evidenced by those cold blue fingertips. Cryoglobulinemia can also cause urticaria, purpura, and even tissue necrosis. All right, let's get into the physical exam and lab workup. It's important to note that, unlike in multiple myeloma, in Waldenstrom's macroglobulinemia, lytic bone lesions and renal insufficiency are rare. On fundoscopic exam, look for dilated, tortuous retinal veins, which is a result of hyperviscosity. This is represented by Sir Waldenstrom's cool retina goggles. We made the strap blue to remind you of veins specifically. Neoplastic cells can infiltrate the lymph nodes, liver, and spleen, which, in about 25% of patients, will cause lymphadenopathy and hepatosplenomegaly. Let's look at some labs. Invasion of the bone marrow can cause anemia, which is present in about 40% of patients at diagnosis. So again, we've drawn in our usual falling H&H abacus. Get a peripheral blood smear and look out for rouleau formation, which is caused by elevated serum protein levels. And just like on the multiple myeloma side of the sketch, we've stacked some archery targets here to convey the stacked coin configuration characteristic of red blood cell rouleau. To diagnose Waldenstrom's macroglobulinemia, get an SPEP and look for that M spike. And remember, for it to be Waldenstrom's, it has to be IgM. Diagnosis also requires a bone marrow biopsy, which must show greater than 10% infiltration of lymphocytes with plasmacytoid or plasma cell differentiation. So again, under the bone banner, we've added a plasma cell themed target, as well as a flag nearby forming the number 10. Immunophenotypic analysis can be performed to look for the typical surface IgM and B cell markers, which also helps exclude other lymphoproliferative disorders. Alright, how about a quick sample assessment? Wally is a 75-year-old man presenting with 3 days of blurry vision, tinnitus, headaches, and bruising. He has no significant medical history. Physical exam is significant for bilateral lower extremity sensory loss, hepatosplenomegaly, and dilated tortuous retinal veins on fundoscopic exam. Hemoglobin is 10.6 with peripheral smear showing extensive rouleau formation. SPEP demonstrates a monoclonal IgM protein of 2.0 grams per deciliter. Presenting symptoms are likely related to hyperviscosity syndrome in the setting of Waldenstrom's macroglobulinemia. Severe symptoms of hyperviscosity necessitate emergent medical treatment. Plasmapheresis, the exchange of the plasma portion of blood, is performed urgently in order to remove the elevated IgM from the bloodstream. Depicted here by another one of Sir Waldenstrom's squires filtering out some IgM shurikens from the mud. Treatment for the disease itself is usually reserved for symptomatic patients. It typically involves chemotherapy, often in combination with rituximab. Alright, let's sum up today's events. Multiple myeloma is a disease of the elderly, with the average age of diagnosis between 65 and 70 years old. Be on the lookout for the classic crab signs and symptoms. C stands for elevated calcium, which can present with constipation, fatigue, and depression, as well as polyuria, polydipsia, dehydration, anorexia, nausea, muscle weakness, and mental status changes. R stands for renal complications. Creatinine will be elevated in 20 to 50% of patients at diagnosis. Rule out reversible causes of AKI first. Also, keep in mind that hypercalcemia itself can cause renal impairment via a variety of mechanisms. Light chain cast nephropathy is caused by development of obstructive light chain casts in renal tubules and is the most common cause of AKI in myeloma patients. Diagnosis is assumed if the serum free light chain assay is really high and if the UPEP shows a predominance of light chains in the urine. AL amyloidosis and light chain deposition disease are less common. They present with proteinuria or overt nephrotic syndrome. This time, the main protein in the urine is albumin. So expect a markedly positive dipstick for protein and a predominance of albumin on UPEP. A stands for anemia, due to bone marrow infiltration. Look for rouleau formation on the peripheral blood smear and expect other cytopenias as well. B stands for bone disease. Patients commonly present with bone pain. Pathologic fractures occur in weight-bearing bones and vertebrae. Patients with suspected myeloma should receive cross-sectional imaging via CT, PET scan, or MRI to assess for lytic lesions or plasmacytomas. Patients with osteopenia, osteoporosis, or osteolytic lesions should be on a bisphosphonate. Remember, patients presenting with signs of cord compression need immediate imaging, usually followed by steroid therapy, surgery, and radiation. Screening for multiple myeloma involves an SPEP to look for an M spike, which is most commonly composed of IgG or IgA, though other immunoglobulin classes can be the culprit as well. In many cases, light chains are detected. A serum free light chain assay should be ordered as well. This increases screening sensitivity and is especially useful for identifying light chain only myelomas, as well as AL amyloidosis. If a monogammopathy is detected, all patients will get a UPEP, which is used to detect antibodies, light chains, and protein in the urine over 24 hours. A definitive diagnosis of multiple myeloma requires greater than 10% neoplastic lymphocytes in the marrow on biopsy, or the presence of a plasmacytoma, in addition to end organ damage, or at least a marker that indicates eventual end organ damage. Treatment includes stem cell transplant and chemo. Radiation can be used for patients with bone pain. Next, MGUS. No end organ damage this time. You'll see an M spike on SPEP that's less than 3 grams per deciliter. The monoclonal protein is usually IgG. It will have less than 10% neoplastic plasma cells on marrow biopsy. Monitor these patients for progression to amyloidosis or plasma cell malignancy. Last but not least, Waldenstrom's macroglobulinemia, caused by a lymphoplasmacytic lymphoma in the bone marrow that's pumping out IgMs. This can increase serum viscosity, leading to headaches, tinnitus, vision changes, polyneuropathy, bleeding, and coma. IgM can also precipitate, causing symptoms of cryoglobulinemia. Look for dilated tortuous veins on fundoscopy, assess for lymphadenopathy, and palpate for hepatosplenomegaly. On labs, expect anemia with rouleau formation on the smear. SPEP will show an M spike comprised of IgM. Diagnosis is made with bone marrow biopsy with greater than 10% infiltration of lymphocytes with plasmacytoid or plasma cell differentiation. Hyperviscosity syndrome is treated with plasmapheresis. Man, what an exciting tournament! That about wraps up our chapter on hematologic malignancies. Let's head on over to the net. IgG!